Thank you very much for the chairman. I'm very glad to be here in Egypt. It's my one of the dream is come true. So I'm going to speak about how to customize surgical technique according to the extent of cholesteatoma. I'm Won-ho Jung from Korea. I work in the Seonggyungan University School of Medicine in Samsung Medical Center. Okay, as you know, cholesteatoma developed from the aortic retraction. Aortic retraction caused by recurrent ET dysfunction, and then tympanic isthmus obstruction. Okay, and then aortic retraction caused by recurrent ET dysfunction, and then tympanic isthmus obstruction. After that, due to disturbed self-cleansing mechanism, keratin is accumulated in the aortic retraction. Cholesteatoma can grow. Why is vas flacida retracted alone without pars tensa involvement? I think there are two factors. One is anatomical factor, one is ventilation effect. Boundary of vas flacida is Rivinus notch on the superior portion and the inferiorly posterior mallear ligament and the anterior mallear ligament. And this posterior and the anterior mallear ligament is so strong enough to prevent vas flacida retraction extended into the pars tensa. And also, mesotympanum is separated from the epitympanum by the membranous fold. Tympanic isthmus is located under the mallear incudal complex around the stapes. It is the only ventilation route from the mesotympanum to the epitympanum. So even though the ET function is normal, tympanic isthmus is blocked by mucosal secretion or mucosal edema or granulation. Negative pressure can grow only in the epitympanic space. It can cause a epitympanic retraction. So once cholesteatoma is developed, it can grow to the mastoid cavity, and then it can grow into the mesotympanum under the mallear incudal complex. So I can divide three types of extent. It's confined to the epitympanum, and then extended to the mastoid antrum, and then extended to the mesotympanum. It can combine with the mastoid extension. So I can evaluate this extent before operation by the CT scan, and then tympanic membrane feature, and then audiogram. In this first case, is confined to the epitympanum. Mastoid cavity is usually clear and well rheumatized, and then soft density is usually lateral to the mallear incudal complex. And audiogram is usually normal. This is very early stage of cholesteatoma. Once it progressed to the mastoid cavity, antrum is filled with the soft tissue density, and then mastoid rheumatization is gone, totally sclerotic or underdeveloped. And medial to the incus and the malleus is clear. So that means it cannot, it didn't extend to the tympanic mesotympanum. So AB gap, there is no AB gap, and the hearing is can be normal. Once it extended to the mesotympanum, usually cholesteatoma extended to the medial to the incus and extended to the stapes. And then a mastoid cavity is filled with the soft tissue density, and then also the rheumatization is gone, and the sclerotic, and then the developed mastoid cavity. In that case, ossicular chain is disrupted. AV gap is, we can find the AV gap. So surgical purpose of cholesteatoma is two reasons. One is the complete removal of cholesteatoma without any residual disease, and then the other is to prevent recurrence. For complete removal, we have to evaluate the extent of cholesteatoma, as I told you before. And then during operation, we should choose the surgical technique for full visualization of cholesteatoma and the envelope resection. And then after operation, we have to inspect the residual cholesteatoma by the, for example, endoscopic exam. So we can choose, depending on the extent of cholesteatoma, one is episiotomy and scotoplasty without mastoidectomy, and then canal wall on mastoidectomy with or without posterior tympanotomy, and the canal wall down mastoidectomy. I show you the several cases. One is case is early cholesteatoma confined to lateral to the incudal mallear complex. As I told before, in the CT scan, there is no soft density in the mastoid cavity. Only small soft density is lateral to the mallear incudal complex. AV gap is there is no AV gap. I did episiotomy to full exposure of cholesteatoma, and then I can remove the whole cholesteatoma completely, and then put the large conchal cartilage onto this defect to do the scrutoplasty. And then after operation, the cartilage is well placed, and then hearing is normal. I show you some video clip, but this is the different patient. Okay, I harvested the cartilage from this conchal area, and I usually use one large piece of cartilage, and you can see the keratin in the cavity, and that I elevated the tympanometal flap. And tympanum is clear. And then I did drill the antipotion to full exposure of cholesteatoma. And then posterior tympanic spine and the anterior tympanic spine is very important for later to place the cartilage for safely. We can see the posterior margin of cholesteatoma and the upper margin of cholesteatoma. And I can elevate the whole cholesteatoma. And then you can see the cholesteatoma is fully elevated from the ground, and then there is no remaining cholesteatoma. After that, I used the harvested cartilage to put. Usually, the place point is posterior tympanic spine, and then anterior tympanic spine. I use the one piece of cartilage. Sometimes, if there is not enough, small piece of cartilage we can add, and then put the fascia inside, and then replace the tympanic membrane. So that's the way I do for eticotomy and then scutoplasty. Second case is cholesteatoma is extended to the mastoid cavity only. You can see there is a clear airspace under the mallear incudal complex. That means this cholesteatoma didn't extend to the mesotympanum. So I didn't do the posterior tympanotomy. I just mastoidectomy, and then we can see the cholesteatoma, and then eticotomy, just like first cases, and then we can remove the whole cholesteatoma completely, and then put the cartilage in. So in that case, cholesteatoma is covered with vesicle. So we have to remove the incus and then take out the head of malleus and then put the partial vascular processes and stapes. And then usually this mastoid cavity is sclerotic. I usually mastoid is obliterated with DBM, demineralized bone matrix. The third case is large cholesteatoma in the attic portion, but past tensa is the same. But mastoid cavity is filled with soft tensity, and then you can extend it to the stapes. So can you see the malleus is a little eroded, and then the medial surface is filled with the soft density. That means it can extend. It did extend it to the mesotympanum. So there is a AB gap in the audiogram.
2 minutes, Dr. Fine.
Okay. And I'll skip and then in this case, the same procedure and the AB gap is gone. Sometimes we need a canal down mastoidectomy. Surgeon, if they think it's impossible for complete removal by canal up mastoidectomy due to poor visualization and then severe inflammation. So to prevent recurrence cholesteatoma, we have to know the two main reasons of recurrences. That's one is inadequate attic reconstruction and the mastoid problem. So if I use the same technique, sometimes 5 years later, cholesteatoma can redevelop. It's because the placement cartilage is not enough, and then there is a mastoid problem. So if there is a negative pressure can develop due to the dead space, and then this cartilage is not big enough to resist this negative pressure, it can migrate into the attic space, and then the cholesteatoma can redevelop. So, you know, after mastoidectomy, ideally we want to airfill the mastoid cavity post-operatively, but like this case is sclerotic and on the development mastoid cavity can be a dead space, not this air-filled mastoid cavity. So filled with blood and granulation, and that this dead space develop negative pressure to cause retraction pocket and the cholesteatoma. So if you did the intact canal mastoidectomy in this sclerotic cases, I think just one summary, one slide is left. Can I see it? No more? Okay. So this is my summary, and then attic space confined cholesteatoma, eticotomy, and scutoplasty, extended to the mastoid cavity, canal up, and then eticotomy, scutoplasty, and then if the mastoid cavity is sclerotic, mastoid obliteration is necessary. And then if the extended tympanic cavity, canal up mastoidectomy with the posterior tympanotomy, and then also mastoid obliteration necessary. sometimes canal down is the story. And then to prevent recurrence, complete scotoplasty with a large piece of cartilage is very important. And then mastered over-retraction is also should be done. Okay, thank you very much.
Is there any question for Dr. Chang? Yes, sir.
Just a simple question. Do you try before in cholesteatoma surgery to preserve the ossicles? To preserve the ossicles for later use in hearing reconstruction?
Like first case, it's not, we can separate the ossicle, we can preserve ossicle, but it's surrounded by cholesteatoma. I usually take out the incus because it's much easier. And then post-op result is very good. So I don't try to preserve the old ossicles.
Yeah, but the canal wall down has also problems that need some time to interfere again, or with usual follow-up, you didn't manage to have any problem?
Canal wall down is, I think is for adult, it's not that provoke any big problem. And then also, in this case, the past tensor is always healthy, so ossiculoplasty is good result.
Dr. Chang, you always use the microscope or use the endoscope for small attic cholesteatoma?
Sorry?
Use always the microscope or you use the endoscope for small attic cholesteatoma?
Usually I do the microscope. I'm not the expert for the endoscope. So I do the microscope, and then for residual disease, I just inspect for residual disease, I use endoscope.
Okay, thanks a lot.
Yeah, thank you very much.
Second speaker, Dr. Abdo is not here. You're talking online, okay.
Join us from Senegal. Hello, Dr. Abdo.
Hello.
Hello.
Okay, thank you. I just want to, first of all, to thank all of you, thank Mr. President and dear colleagues. Just want to say that I come from a French-speaking country. Then I would like you to apologize me for my bad English. I would like to thank the committee of organization and Professor El Badrin for inviting me to attend this important conference. Stop working? Yeah, okay. The management of middle ear pathologies, in particular otitis media, cholesteatoma, in remote and low resource areas and in low and the middle income countries is a real challenge. The otologic surgeon encounters difficulties linked to several endogenous and exogenous factors, pushing him to adapt his clinical reasoning, his preclinical investigations, his operative techniques, as well as his post-operative follow-up. This surgeon's objective is to juggle between two maxima and two minima to treat with the minimum of means the maximum number of patients with maximum success while minimizing risks. The management of cholesteatoma in children in environments with limited resources has several particularities. contextual and clinical particularities in paraclinical investigation, in surgical techniques, and in post-operative follow-up. The clinical context is marked by long delay in consultations due to the need to visit traditional practitioners, difficult access to specialized health facilities, and late referrals. The consequences are spread of the disease, making its eradication more complex, erosion of the obstacles, complications like mastoiditis, damage to the facial nerve, etc. And cholesteatoma in children is reputed to be more aggressive than in adults. We have also many lost of follow-up. On this picture, we have a young patient with left mastoiditis with retroauricular filling, detaching the ear pinna downwards and forwards. Regarding imagery, CT scans, which are essential for assessing extension and detecting complications and anatomical variation, are available almost everywhere. But high-resolution CT scans with thin section are not always available, and it is difficult to find competent radiologists with the interpretations of TB imaging, temporal bone imaging. MRI is now essential for post-operative follow-up after canal wall up tympanoplasty, when CT shows suspicious disease, but it is rarely available and expensive. And these imaging is not always available. We want, as this imaging is not always available, we want to wait for it before starting treatment. Instead, we will rely on the clinical features to anticipate certain complications. Operative particularities are marked by a choice generally between CWT, canal wall up tympanoplasty, and canal wall down tympanoplasty. CWT has many advantages, but requires a second look, which presupposes a compliant patient who respects post-operative follow-up and appointments, which is highly unlikely in our countries, and or repeated CT scans and sometimes MRI, which is difficult to achieve in the context of poverty. As a result, the therapeutic option in the majority of cases in our context is CWD, canal wall down tympanoplasty. This option is reinforced by the extent of the lesions and the imperative need to control difficult areas such as the sinus tympani, the facial recess, and the anterior attic. The posterior approach is usually used as it gives access to the entire mastoid. If necessary, an ossiculoplasty could be performed as early as the first operation when conditions are favorable, as there is no guarantee that the patient will be seen again for a second stage of ossiculoplasty. Facial pop and top are luxurious. They pose problems of tolerance and risk of extrusion. We use autologous materials, ossicles, especially the incus, freed of epidermal debris and cartilage. Obliteration is achieved using fascia temporalis, bone, powder, cartilage, and muscle. Beforehand, you need to make sure that the disease has been completely extirpated from the body, mastoid, and other difficult areas mentioned above. Thus, a large myeloplasty will allow better monitoring. Traditionally, patients with recessed cavity would be followed up every 6 to 12 months. However, this can be difficult for patients who live far away, but fortunately, an obliterated cavity with a large myeloplasty accumulates less debris and can be cleaned under direct vision by local non-specialist nursing staff using a headlamp. If possible, the ENT specialist will see the patient again to check for residual or recurrent disease. In conclusion, dear colleagues, autologic surgical techniques in resource-limited areas must be adapted to suit the situation. In the case of extensive middle ear cholesteatoma in children, canal wall down tympanoplasty combined with a large myeloplasty and immediate ossiculoplasty using autologous material could be a good therapeutic option. Thank you for your attention.
Thanks, Dr. Abdo. Is there any question to Dr. Abdo?
Now the next speaker, Professor Makhlouf Ben Zamet, middle ear cholesteatoma, mastoid obliteration.
Ladies and gentlemen, Mr. President, good morning, everybody. Let me congratulate Professor Badreddine for this successful meeting. And let's start with my presentation. So if I show you these pictures, and I asked you what's this, you will tell me on the first, on left, posterior superior retraction pocket with cholesteatoma, attic cholesteatoma on the second, Bondi modified technique and recidive of cholesteatoma, congenital cholesteatoma in the center, and believe me, even the second case here is congenital cholesteatoma, and after that, after infection, there is opening on the attic. Cholesteatoma residual here, you can see it on reconstructive tympanic membrane. So one keyword here is cholesteatoma. So what's cholesteatoma and what to do? Initially, and for us, we agree all that cholesteatoma, one word and one keyword is to treat. And treatment of cholesteatoma is surgery. But surgery for cholesteatoma still problem. Why is this? Why surgical treatment of cholesteatoma is problem? Because we don't know the exactitude of etiopathogenesis, which is mysterious. And second one, for surgery, you have seen many techniques. So I'm talking cholesteatoma surgery from the aeration to total obliteration of the middle ear. And let me talk about mastoid obliteration and its historic event in the past at the beginning of the 20th century. And many techniques, many flip or now biomaterials like hydroxyapatite or bioglasses that we use. We have started this technique since now 10 years with this great man in Marseille, Professor Jacques Magnon, who teaches us this technique, mastoid obliteration. For us, we started with bony obliteration. And why we started this technique? Because as you can see here, there is a problem, and to avoid the risk of recurrence and reduce the risk, we must know that the change of 6 micrometers in the thickness of middle ear mucosa change the pressure by 1 kilo. So the theory of gas exchange is very important to know, and it leads to the high recurrence of recidivism. And if we do obliteration, we stop this risk. On the last or 2012 in Nagasaki conference, a paper regarding the middle ear regulation pressure to establish a good pressure in all the middle ear cavities was enhanced. So when do we perform this kind of surgery? First of all, for cholesteatoma surgery, open or close technique for us, the result is at the end, and I will show you. For the rehabilitation of open technique in Algeria, before we did many open techniques, and for other indication like cholesteatoma on a deaf ear, translabyrinthine approach, traumatism, or malignancy of the temporal bone. So, for cholesteatoma surgery, we must make a roadmap before starting surgery. And this roadmap include CT scan and the screening of audition. I will resume our technique in 6 steps. The first one is wide exposure of the mastoid. The second step is to harvesting. The third one is the surgical technique, closed, open technique, transcanal, etc. So we didn't have a technique, but we must perform a strategy, a roadmap before starting our surgery. And the fourth one is middle ear reconstruction, ossiculoplasty, and the external auditory canal reconstruction, and in last, mastoid and epitympanon obliteration with different materials. So we, in most of cases, perform a retroauricular approach with skin incision. We must be careful on the posterior auricular muscle to put it in the right place to avoid any deformities of the pinna, especially in kids. We perform an anterior flap, and here we start harvesting. So what we must know when we start harvesting, so it depends on the kind of surgery. If it is a first hand, so we have our roadmap, and we can take all the material that we need. If not, and we don't need many materials, so we start our surgery, and at the end, we take our materials. Here is to summarize some steps. Perichondrium from the concha. After that, we take cartilage also from the concha. Cartilage like this, and after that, we will cut it, a thin plate of cartilage, and we take also some pieces of cartilage to reconstruct at the end of our surgery the protympanon, and to put like a support to support our cartilage. We take not for all our cases cortical mastoid bone. I will show you why. To sometimes make ossicles to reconstruct the ossicular chain, and sometimes to reconstruct the posterior wall. We cut the cartilage manually, and we make a very thin plate of cartilage that allowed us to reconstruct eardrum and enhance the tympanic membrane at the end. For the bone pâté, we prefer taking bone pâté, it's easier, and cheaper for us and for our patient, with a cutting burr and a little bit irrigation. So be careful, don't burn the bone. This bone is prepared with antibiotic solution. In general, fluoroquinolone antibiotics, and we make this on the table before starting our surgery. So all this step is harvesting. For the surgery now, in the majority of our cases, we did an intracanal approach. And for us, canaloplasty is mandatory. We make a 360 incision of the external auditory canal, but the incision don't be in front each the other with decay at the anterior part, the incision. After that, we start our dissection. This is the right ear, and as you can see here, attic cholesteatoma. But on the CT scan, there is a mastoid invasion and very important development of cholesteatoma in the posterior part of mastoid. So we liberate the inferior part of the tympanic membrane. After that, we try to separate the illness zone, which is epitympanum, from the healthy zone, which is the tympanic membrane. Here is very nice, and the key of this region, we must open, we do the anterior tympanotomy, and we have a look on the anterior part of our cavity. We separate epitympanum from mesotympanum. Here you have in front of you the head of the malleus, and we continue our drilling by performing canaloplasty at epitympanotomy via the external auditory canal. From the anterior to the posterior, our key is, and our principle is that cholesteatoma for us is cancer, and we must remove it as a cancer. And the key to do that is to be behind cholesteatoma. When ossicular chain is eroded, like you can see here, we start by disarticulate incus from stapes, and after that, we cut the head of the malleus, and we continue our drilling of the epitympanic cavity, and from anterior to posterior. After that, we stop, and we will go by the posterior cavity doing a large mastoidectomy. Here, cholesteatoma developing in attic. This is the push or the cyst of cholesteatoma, which was on the stapes in the fascial recess. Here you can see the fascial nerve, the second portion in front of you. So we put cottonoid to protect the cavity, the tympanic cavity, to avoid any dispersion of epidermic cells to epitympanum and mesotympanum and protympanum also. And we continue our drilling with an in-out technique from interior to exterior to remove and to expose all cholesteatoma. And I repeat, we must be behind cholesteatoma. We must be behind the matrix cholesteatoma to avoid any risk of recurrence. And the recurrence, we have less than 3%, even with this technique. So I continue our mastoidectomy. Here we are at the end of the development of cholesteatoma. From posterior now to anterior, our cholesteatoma is pediculated on the lateral semicircular canal, because sometimes, and it is seen with CT scan, if we can have dehiscence of the lateral semicircular canal. So we are behind cholesteatoma. We dissect it from posterior to anterior. We pediculate it, and after that, we remove all cholesteatoma. And we are sure that we remove all cholesteatoma. A cutting burr to ensure and to harmonize the cavity. After that, a diamond burr. And when cholesteatoma is removed, we will start our reconstruction of middle ear cavities. So here you can see the cotonoid here to avoid any dispersion of epidermic cells in the other parts of the tympanic cavity. The last part to remove cholesteatoma on the fascial recess. Here you have fascial nerve and cholesteatoma is removed. This is one case to show you the global strategy, and I'm talking about strategy and not a technique, and the difference is here. And look at this last moment. We are behind cholesteatoma. We must take it from behind. Cholesteatoma for us, I repeat, is cancer. And here is pediculated on the lateral semicircular canal. Now we'll start our reconstruction. So we put celastic sheet. After that, our perichondrium. We put our cartilage on the anterior part. We stabilize the anterior part of the external auditory canal. After that, we put our prosthesis, partial or total prosthesis. You can see here a partial prosthesis because we can preserve stapes. After that, we put our petal of cartilage, and we will obliterate all the epitympanum space from the cystubal recess to, after removing, of course, of the cog to the posterior. Thank you very much. Time is up. I would like to show you a reconstruction with bone alive, but thank you very much. If you have any question.
Yes, thanks to any questions? Dr. Makhlouf, you do obliterations for all cholesteatoma surgery. You obliterate all the cavities?
No, it depends on the cholesteatoma, the site of starting, the starting point of cholesteatoma, and of course the extension of cholesteatoma in all middle ear spaces. So we perform a strategy. If it is an epitympanon on the lateral space epitympanon, so we do it with a transcanal, maybe sometimes with endoscope, and that's all. So when we have a huge cholesteatoma, I had 2 cases to show you, but time is not enough to show all the videos. So more the cholesteatoma is aggressive, more we are 2. That's all, but not for all cases of cholesteatoma.
Excuse me, Dr. Makhlouf. If there is a cholesteatoma sac on the oval window with erosion of the ossicles, is it better to be removed, or what you manage?
If ossicles are eroded, we remove ossicles. This is a rule for us.
I mean, if there is some cholesteatoma sac over the oval window.
Over the oval window.
Yes.
Study this. There is releases of stapes, superstructure of stapes.
Dissected or leave it as it?
No, I dissect it, but at the end of the surgery, like I tell regarding the lateral semicircular canal. At the ending of the surgery, we dissect cholesteatoma and we prepare graft, maybe a fracture or lesion of the foot plate.
Thank you.
You're welcome.
Thanks, Dr. Makhlouf.
Thank you.
Next speaker, Dr. Kemal Jouro, new development and pathogenesis of cholesteatoma.
Good morning, dear colleagues. I would like to thank the organization committee for this nice meeting. I am going to talk about the cholesteatoma new findings and development. How can I? Okay. As we know, cholesteatoma, a progressive, destructive, benign, aggressive epithelial lesion. It's characterized by uncontrolled proliferation of the keratinocyte in the matrix. It's characterized by the recurrent foul smelling in the surrounding structures and resulting in numerous complications. As we know, there are 5 theories for the description of the pathogenesis. In all of these theories, retraction and proliferation theories is most acceptable. When we look at the cholesteatoma histology and cellular activity, this consists of the 3 parts. The inner parts, inner cystic parts, contain keratinocyte and corneocytes. And the cystic part is surrounded by the matrix and perimatrix. The perimatrix consists of the fibroblast and granulation tissue, and there is an interaction between the matrix and perimatrix. As we see, the cholesteatoma matrix layer, perimatrix, and cystic component. This interaction induced by the inflammation, middle ear inflammation, and it's caused to the hyperproliferation of keratinocyte and fibroblast. This inflammation and interaction caused to undifferentiation of the keratinocyte. And undifferentiated keratinocyte produce several cytokine and pro-inflammatory cytokines. And in a vicious circle, fibroblast secretes the another growth factors. The relation can be seen on this diagram, and interaction between the keratinocyte and fibroblast. When we look at the cholesteatoma pathogenesis again, in 1974, Dr. Toss proposed the invagination and retraction pocket. The previous speaker talked about the retraction pocket, and the main situation, the hypoxia of the middle ear. Normally, the middle ear oxygen rate is between 5 and 10%. It's lower than the ambient air. In chronic Eustachian dysfunction, decrement oxygen ratio in the middle ear cavity leads to hypoxia, and hypoxia activates hypoxia-inducible factor 1 alpha, and this factor binds to the hypoxia responsive elements, and this binds modulates the transcription of some genes. The cholesteatoma is important. Hypoxia is important in the developing cholesteatoma. Hypoxia activated hypoxia-inducible factor 1 alpha, cell proliferation, cell metabolism, angiogenesis, cell transformation, and cell senescence. And this all pathway using during this activation. In this study performed by the Chen and his colleagues, hypoxia-inducible factor 1 alpha might expedite cholesteatoma keratinocyte proliferation, partly by increasing endothelin converting enzyme 1. And in another study supported this findings. The properties of keratinocyte in the cholesteatoma matrix, they induced by the hypoxia and uncontrolled keratinocyte proliferation and controlled cell death in other name, apoptosis. When we look at the molecular mechanism of the cholesteatoma, there are some genetics defects or abnormalities. Infection is important because during the cholesteatoma, after the inflammation, different cytokines released and the immune response of the patient is important. Apoptosis, exist of the apoptosis is important because it's differentiate cholesteatoma from the tumors. Mitophagy and autophagy defects can be seen. Some angiogenesis and bone resorption by the osteoclast activating factors and cholesteatoma keratinocyte controlled by the apoptosis. In our previous study, we enrolled the 42 cases with the acquired cholesteatoma, and they immunohistochemically evaluated by the P67 and P27 antibodies. And as we see, the positive immune staining in cholesteatoma in here, and negative immunostaining with the P27 in cholesteatoma. After this, if cholesteatoma before the turning the external auditory skin has the lower basal layer cellular proliferation and higher cellular activity, show us the worse prognosis. In another study, we aim to clarify the keratinocyte, why the keratinocyte undifferentiated. And we look at the raw activity. The raw activity is same in the cholesteatoma and the external auditory canal skin. And ROC2 activity is lower in the cholesteatoma matrix. And ROC activity also is lower in the cholesteatoma matrix. Results and discussion of our studies. The expression of the raw kinase enzyme was significantly lower in cholesteatoma, and ROC activity is decreased in cholesteatoma matrix. Human primary keratinocytes have a finite lifespan in culture. Presence of ROC inhibitor increased the proliferation and immortalization. After the removal of ROC inhibitor cells, the cells slow in growth and senescence. When ROC was inhibited, differentiation could be inhibited. The ROC kinase inhibitor like they increase cellular proliferation and migration, and decrease ROCK activity, increase cell proliferation and inhibit of the keratinocyte differentiation. And ROCK kinase pathway has an important role in the development of cholesteatoma and keratinocyte differentiation. When we briefly look at the pathogenesis, due to the Eustachian dysfunction, middle ear atelectasis can be developed, and after that, retraction of the keratinizing stratified squamous epithelium, especially in the pars flaccida, and hypoxia and oxygen rate below the 5%, and hypoxia inducible factor 1 alpha activated, and keratinocyte undifferentiation and proliferation activated. And this activation seen controlled by the ROCK kinase pathway. And after then, cholesteatoma and complications can be seen. The features of the cholesteatoma has an proliferation, aggressivity, migration, invasion, differentiation, recidivism, apoptosis, secretion, and cell shape changing. All of these activity controlled by the ROCK kinase pathway. And we aim to a possible relation between the genetic expression. We look at the ROCK1 and ROCK2 gene expression and polymorphism in cholesteatoma patients. And we saw that if patient has C allele, it decreases the cholesteatoma development rate. Notes to take home, hypoxia is an important factor in development of cholesteatoma. Keratinocyte undifferentiation is responsible from the aggressivity. Fibroblast and keratinocyte interaction is vicious, as a vicious circle. Hypoxia inducible factor alpha is taking a key role in the development, and it modulates the transcription of some genes, and this stimulation controlled by the ROCK kinase pathway, and ROCK kinase pathway is under the genetic control, and having C allele decreased risk of developing cholesteatoma. This is cause of why in patients has the retraction pocket cholesteatoma develop, and in another don't develop cholesteatoma. During cholesteatoma surgery, created an enough external auditory canal or obliteration of cavity, or the pneumatization, maintain a good pneumatization is important. That's all. Thank you very much for your